she might lose the ability to breathe, and checking her breasts for lumps, her urine and her stools. She was visiting her GP 3 to 5 times per week, and understandably her mood was very low and had been very low for quite a long time. When I asked her about suicidal ideation, she was very adamant that this was not an option for her. She told me that she was terrified of dying, so suicide was a very unlikely choice for her. She said that this fear of death had been lifelong, and that she had always avoided talking about it in therapy, as well as avoided thinking about death. Despite being very explicit in the first session that she didn't want to talk about this in therapy, she described frequent things such as having panic attacks about the thought of death. So she told me the night before she first came to see me, she'd been lying in bed when she started to have an image of herself lying in a grave, and that's when she had quite a severe panic attack before she came to see me the next day. In terms of her psychosocial background, one of her earliest memories was around age 4. She had quite a vivid memory of something her mother said to her when her mother had lost someone had passed away in the family, and Anna attempted to comfort her mother. She was quite a religious child and attempted to comfort her mother by saying, you know, it's okay, Mum, they'll be in heaven now. And Anna describes having a very vivid memory of her mother saying quite bluntly to her, there's no heaven, you die and that's it. And these words really stuck with her throughout her life. At around age 6, her health anxiety began. She was raised around her grandparents, and her maternal grandmother had very severe health anxiety and would frequently check her own body. And so Anna began to start modelling and imitating some of these behaviours at a very young age. At around age 8, she began to develop OCD. As a child, the OCD focused on religious concerns and rituals, but as an adult, this sort of morphed into more contamination concerns. So things such as insisting to check the expiry date on cartons of milk when she would buy a coffee from a cafe. Between the ages of 8 and 13, her stepfather with whom she lived began to groom Anna, and this culminated in an incident of child sexual abuse. At around age 15, Anna's health anxiety and depression severely increased. She stopped attending school at this point because while she was at school, she would be frequently troubled by distressing thoughts about her mother possibly dying while she was at school. And she became suicidal at this point, but she told me that it was her fear of death that stopped her from ending her life at this time. Between the ages of 17 and 19, she suffered from anorexia nervosa, and around the same time, she had a friend who committed suicide. In the weeks leading up to this friend's death, the friend had apparently been trying to call her, but Anna hadn't picked up the phone for one reason or another. So when this friend eventually did commit suicide, Anna had a lot of guilt and regret about not picking up that phone call. And when she went to the friend's funeral, she found this very distressing and essentially avoided every funeral ever since then. She then began a relationship with Mark, the father of her children, who also had OCD. And she, at 32, fell pregnant. The pregnancy had a lot of health complications for her. She developed gestational diabetes and required surgery on more than one occasion for this pregnancy, and her depression at this point again significantly increased. At 34, she fell pregnant a second time. This second pregnancy was unplanned and unwanted, but she gave birth anyway, and also this pregnancy had a lot of health complications for her. Her OCD symptoms, which she'd had throughout her life, disappeared for a few years, but then re-emerged shortly prior to treatment. So in terms of Anna's revolving door, currently she met criteria for persistent depressive disorder as well as somatic symptom disorder. So for Anna, her health anxiety was very much focused on somatic symptoms, such as when she experienced a migraine, she worried that it was a brain tumour, or if she saw a bruise on her arm, she would worry that it was a spider bite. So currently she was meeting criteria for these two disorders, but previously she'd suffered from OCD and anorexia nervosa. And she'd had four or more therapists since the age of 15. So I think she provides a good example of what the revolving door tends to look like often in clinical practice, in that it wasn't the case she was presenting with purely health anxiety and that was the only thing that had ever troubled her. She had quite a complex history of different diagnoses. In terms of her current diagnosis and her health anxiety, it was having a severe impact on her life. So she essentially was planning all of her days around how near she was to medical centres and her GP. So all of the time she spent with her children, visits to parks, visits to shopping centres, all had to be planned keeping in mind her GP's location or the location of other prominent hospitals in the area. She was also avoiding a lot of things. She would avoid any kind of exercise, including just walking to the end of her block because of the change in heart rate, which she found distressing. She was also unable to drive for more than 10 minutes because she didn't want to get too far away from these medical services that she was quite attached to. And because of this, she was also unable to return to work because her previous workplace was almost an hour's drive away. She was also concerned that her health anxiety was affecting her relationships. She told me that she wouldn't let any friends know her dirty little secret. And so because of this, she'd ended a lot of relationships and frequently had to cancel plans with people because she became quite distressed about her own health. So essentially it was having a really severe impact on her, and one of the things that finally prompted her again to return to therapy was her fear that this health anxiety may be having a very severe impact on her children. She'd started to notice her eldest child checking his own body and asking her a lot of questions about his health, which was a big motivation for her to seek help for this. So it was having a very severe impact on her life, and understandably her mood was very low at this point. So in terms of her formulation, this here is sort of a standard formulation of health anxiety and purely the health anxiety for Anna. So you can see at the top there we've got some background factors that were clearly a part of her presentation. So there was a family history of mental illness there. Her mother suffered from agoraphobia and depression, and the grandmother had that severe health anxiety. Of course, the grandmother was also modelling various checking behaviours when Anna was a child, which she'd learned to imitate. She'd also had a long history of physical health problems, such as those during the pregnancy as well as during her adolescence. And there was also the incident of child sexual abuse, which understandably had a strong impact on her. So these various background factors led to core beliefs, such as other people can't be trusted or other people won't protect me. So, her mother didn't protect her when she was being abused, and the doctors didn't protect her and keep her healthy and safe during her pregnancy. And also, I think a common core belief among this sort of population, which is the idea that my anxiety keeps me safe. So she clearly believed her health anxiety had generally kept her healthy. Her anxiety could also be triggered by internal and external triggers, as we can see on the left. So her internal triggers could be thoughts about illness, changes in her heart rate, so she suffered from tachycardia, or things like a migraine. And external triggers for her anxiety included seeing health campaigns for things like lung cancer, anything on TV such as medical shows or watching the news, hearing about illness. So her anxiety, of course, then led to bodily sensations such as headaches, dizziness, a tight chest, and increased heart rate, which Anna would appraise as being a serious issue. So, my headache is actually a brain tumour, or I'm having a stroke or a heart attack. And then she was engaging in various behaviours which were maintaining this cycle of anxiety. So she was frequently checking her pulse, her blood pressure, even checking Google to check her symptoms. She was also seeking excessive reassurance from her GP, as well as the father of her children, and a lot of avoidance on her part, so avoiding driving, walking, watching TV, and also the safety behaviour of carrying those very heavy machines around everywhere she went. So this here is sort of a standard formulation of health anxiety taken from Fura, or based on Fura and colleagues. If we were to include more of a death anxiety focus, there are some things here that look a little different. It adds, an extra layer of depth and complexity to this picture of this woman's life and condition. So in terms of her background factors, we now have to take into account those really powerful words of her mother when she was 4. So that message that you die and that's it, that's all there is. So there's that incident when she was quite young, but there's also this awareness of mortality, what William James refers to as the worm at the core of human existence, which all of us tend to develop around the age of 6 or 7. So that's also, I think, something that's important to take into account with this kind of formulation. And then, of course, there was her friend's suicide at age 18, both the loss of this friend, but I think also the events associated with the death, such as the funeral, which was very distressing to her. In terms of her core beliefs, so those other 2 core beliefs remain unchanged, but I think there's another core belief which is really important to take into account for her, in that she clearly believed that her fear of death had kept her alive and continued to keep her alive. So Anna very strongly believed that she was, in her words, she was meant to be scared of death. She was meant to have this fear because it had stopped her from committing suicide all those years ago. In terms of her triggers, this now is really just generalized to thoughts about illness, but also about dying. So the image of her lying in the grave is clearly related to this formulation. But also I think the importance of this kind of formulation, including the death anxiety, takes into account different things that might not fit into that picture, that original model of her health anxiety. So Anna also frequently worried about terrorism threats. It didn't quite have a sort of generalized anxiety disorder feel. It was really just the terrorism, which, if we're solely using that sort of classic health anxiety model or formulation, the terrorism doesn't really play a role there. But when we take into account a more general death anxiety focus, clearly that's playing a role. So she would avoid visiting places that might be the subject of terrorist attacks. And in terms of the maintenance cycle of her anxiety, the only other thing to add, I guess, is that appraisal of sensations isn't just I'm having a heart attack or I must be having a brain tumor. It's fundamentally this idea that I'm dying. There's something physically wrong with me, and this sensation I'm having must mean that I'm going to die. In terms of a treatment plan for Anna, her goals were to reduce her daily levels of anxiety. In particular, she wanted to increase her ability to drive, to reduce her checking, which was taking up a lot of time, and to reduce her reassurance seeking. Her goal was also to reduce her GP